All right, good afternoon, everybody. I'm sure with the nice lunch, everybody is ready to doze off. But what we'll try and do is we'll try and look at a few cases and try and point out some of the common errors that I see when my fellows who are, I'm a program director, we have nephrology fellows in training in our institute, and we also have an interventional nephrology program. So the fellows rotate through the interventional nephrology suite as part of their 2 years fellowship. And then also we get a lot of internal medicine residents who rotate through nephrology. And I've observed over the years a very common error in terms of using ultrasound guided cannulation. So I'll try and highlight some of those and see if we can impress on how to use the correct technique. So why is it important? Because I think it's clearly shown by several authors that the risk of blind cannulation is high, puncture of arterial puncture, as well as complications of pneumothorax, hematoma formation is a realistic problem. So if you use ultrasound-guided cannulation, you should be able to decrease these costs to the patient. But whenever you try and talk to some of the private colleagues, even in our city or outside, a common pushback is, why do I need an ultrasound? I've done hundreds of these blindly. I know what the landmark technique is. Ultrasound is for dash, 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 dash. I'm not going to say anything. And why spend more money on doing an ultrasound when I can get most of the access without complications? One of the things that one of my mentors had told me years ago, if there is a complication that has been reported, it's going to happen. And if you can use certain techniques to lower that risk, I think that is what you need to try and strive for every patient that we use. So in the United States, they've kind of surveyed, different organizations have surveyed their members. Anesthesia, usually most of the anesthesia guys in the United States are using some sort of an ultrasound-guided cannulation in most of the centers. The critical care is about 50% or so. So depending upon where we look at, even in the United States, even now, where we believe it's the standard of care, only about at the max, 7 out of 10, 70% of the people would use ultrasound-guided cannulation at the time of catheter placement. So I was alluding to the differences in how you approach this technique. And you can divide these techniques into what we call the static ultrasound, where you just use ultrasound, you mark the vein, you make sure that the vein is patent, and then you try and cannulate the vein. Or when you use it real time should mean that you actually see the needle go into the vein. And that's the critical part. You have to visualize the tip of the needle through its entire journey from the tip of the skin, the moment when it enters the skin, through the subcutaneous tissue, into the wall of the vessel. And that passage is very important, because if you do not see where your tip is, you have a false sense of security that you're watching where the vein is, and you may have gone in about 4 or 5 centimeters. There's one of my fellow who makes me nervous all the time. He goes into the vein and he's already 5 centimeters in. I'm like, the vein is only 1 centimeter deep. Where is your tip of needle? So the standard kit is pretty much the same. There are some probes, linear probes, that have a guiding probe on it. I think they are useful. They do come in different sizes based on how deep the vein is, because the angle is different at which you would want to try and go in to get into the vein. If the vein is really superficial, you want to try and go in at a very acute angle, whereas if it's deep, you want to go in at a bigger angle to try and get the vein. Well, one of the key things to realize is that ultrasound, the linear probe, is only about 3 or 4 millimeters, 5 millimeters wide, and is giving you a cross-sectional view of the vein. So you only see what's directly below that probe. You do not see the vein a centimeter above or a centimeter behind that probe. So that's a very important thing to kind of keep in mind. So when you're looking at the vein, you can see the cross-section, you can identify the vessels around it, and what you see on that other image is the tip of the needle, and that's your ideal picture. For billing purposes in the United States, there is a code for it, and Medicare requires that we save this image of that needle inside the lumen of the vessel to be able to get that reimbursement for that billable code. Now you can do what we call a longitudinal view of the vein. Now benefit here is that you will see the vein in a much longer area, so the chances of trying to make sure that the needle track is visible all throughout is going to be a lot better. So the needle may traverse through that area, and throughout the path that you take to get to the vessel, you should be able to track the needle all along. There's some computer glitch? Okay. So this is one of the video where you see the vein is really small. It's probably about 1, maybe 2 or 3 millimeters wide, and you're trying to cannulate it with the needle. The needle tip is visible, and then it kind of goes away, so you try and make sure that your probe is adjusted so that you can see the needle probe exactly, the needle tip exactly over the vessel wall. Now, if you change it to the longitudinal long axis view, it can help you a lot easier. The long axis, you can see the needle a lot clearly. The tip is inside the lumen of that vessel now, and now you can just very easily pass your guide wire, and that should be all visible to your eye. If you follow this technique, you will never see an arterial complication. But if you do what we call the static, you just visualize the vein and then you go blind. And most of my fellows would go, they're looking at the vein and then they put the syringe on it, and now they're going with that negative aspiration. The landmark technique where what you're looking for is blood coming back of the vessel into your syringe. What you do not want to do is look for the blood. What you really want to look is see the tip of the wire go into the needle. So one of the key concepts to try and get your hand over it is, as the needle tip moves and it goes forward, you need to move your probe along with it, or fan your probe so that the ultrasonic beam is going to follow the tip of the needle. Now only you can tell where your needle tip is, because as you're advancing it, you know that it's going forward. You want to make sure that either you move your probe forward or you just tilt it, you put an angle on it so that you can keep tracing the tip of the needle as you go forward. So like you said, there are 2 approaches that you can use, the transverse approach or the longitudinal approach, and there are some advantages of each. Here you can see the 2 approaches kind of simultaneously. Just looking at, again, on a patient that we did recently, I tried to record these to illustrate the 2 approaches, the cross-sectional view and then the longitudinal view. I try and encourage my fellows to not use the syringe, and if you do not have the syringe, you will be forced to watch the tip go into the vessel lumen so that you can confirm that you have achieved ultrasound-guided cannulation. And once you're in the vessel lumen and you see the tip of the needle in there, now I can very easily pass my wire. I do not need to get blood back to confirm that I'm in the vein. And I use a micropuncture needle and I do it blind without the syringe, because with a micropuncture needle, the caliber is so small that you don't have any risk of air embolism. But if you're using an 18-gauge needle, I would advise that you put the syringe on it and not go blind without the syringe and opening the air embolism. The micropuncture comes as a regular kit. It's a 21-gauge needle with an 0.18-inch wire along with that, and then there are 5 French dilators. We've seen these slides multiple times. The anatomy is different for every patient. It doesn't matter whether you look at the IJs, you look at the femorals. They are going to be in different locations. They're going to be in different locations based on where in the neck are you looking at them. If you go at the base of the neck, they may move medially. If you go a little higher in the neck, the position and the relationship of the artery and the vein may change. So you really have to be cautious of where you are, and I think the key is to watch that needle go into the vein. So over the years, I think a lot of people have looked at that ultrasound-guided cannulation does save complications. It saves time because you are not going to have those arterial sticks, and every time you get an arterial stick, now you got to hold pressure for at least 3 to 5 minutes to make sure that you're not going to form a hematoma there if you're doing good practice. So ultrasound cannulation does decrease the number of sticks to less than, more than 3 sticks were 0 when you use ultrasound cannulation, and the operating time was much less when you used ultrasound cannulation. I think it'll take you some time to make sure that you get ready, but once you're ready, I think it should go fast. So I think if you follow the proper technique, the risk of complications is really going to be low. There are some studies that have challenged that, and I believe if the technique is not followed properly, the risk of complication may actually be even higher. There's a lot of debate about real-time ultrasound-guided kidney biopsy versus landmark, where you just mark the ultrasound, mark the kidney, and then do kidney biopsy by ultrasound marking. Almost the same thing. If you do not watch the tip of the needle go into the needle, the kidney cortex, while you take your sample, there is a chance that the needle may be actually deep when you shoot, and you will have a much higher risk of bleeding. And I think the key part is, if you want a CVC, if any of us would want a central venous catheter placement, would we want a blind stick? And if you answer no, then I think the patient also demands and should get ultrasound-guided real-time cannulation with the proper technique.